why this window of conception is in the middle of the cycle. And if you were using a natural fertility type contraception protocol, intercourse would be avoided for 5 to 7 days prior to ovulation and for at least another 3 days beyond ovulation or the middle of the cycle. The cycle length is the other thing that comes into play when you deal with this kind of a problem, and that looks something like this. If you look at the frequency of cycle length, or I should say frequency, I should say cycle length by, if we get it right, I get my axes correct. Frequency, cycle length by years of age. In humans, you go from essentially an infinite cycle length prior to puberty. So puberty is occurring somewhere, somewhere here. And menopause occurs out here. So what happens in between is that you've got a very highly variable cycles occurring prior to puberty and at or slightly, or at or after, pardon me, at or near the timing of menopause. In between, these are fairly stable, somewhere around 29 days. Okay, so we've got this U-shaped curve, and there are perturbations of it that can occur. So if you have a pregnancy, you're obviously not cycling, and so the cycle length would go way up. But following a pregnancy, you essentially follow this kind of a curve down, and you'll see why that makes sense a bit later on. But this would be pregnancy. And usually it's plus lactation. So you kind of mimic what happens near the time of pregnancy. The nature of the female cycle is such that you've got ovulation near mid-cycle in one cycle, and that is occurring here, and then you've got, that won't occur in the absence of pregnancy until out here. So these are days.
Can you say that again?
Okay, so if you've got ovulation occurring up here, so these are events. If ovulation is occurring out here and won't occur again to this point in time, in between, what happens? You've got, in the absence of a pregnancy, what's going on in the ovary? So you shed the egg, then what happens? So you form a corpus luteum. And what does the corpus luteum do? What does the corpus luteum do? What is it there for? No. What does the corpus luteum do? Anybody ever hear of progesterone? It's not a storehouse. It is a manufacturing plant. Okay? It makes progesterone. So this goes to an elevation in progesterone. Okay? And what if fertilization does not occur? Does that persist?
No. Yes.
Who says yes? What keeps it from failing? Only if you've got a pregnancy. Okay. What if pregnancy does not occur?
It actually
No. What happens to the corpus luteum if a pregnancy or fertilization does not occur? Okay, you guys got to go read your textbook. Okay. This fails. What happens if it fails? What happens to progesterone levels? They drop. Okay.
I said that, didn't I say it dies?
No, you didn't. Somebody else shouted louder than you did if that's the case. Okay. So progesterone crashes along with the corpus luteum, and what happens in that case? What happens out here? If we're dealing with a primate, what's happening there? As progesterone levels are falling, what? Okay, the progesterone levels are falling. What's happening in the endometrium? Okay, it's being lost or degraded or resorbed. What do we call this period of time in a primate? Menstruation. Menses. Okay. This would be day 0 of the next cycle. The cycle leading up to this ovulation. Okay. So you've got things going on in the ovary, you've got things going on in the uterine endometrium, and those show up as menses in primates. What about non-primates? What happens to the endometrial lining if you don't get a fertilization? Pardon? It gets thinner. Any guesses as to what happens to it? How does it get thinner?
Maybe it loses like some vascularization.
It's losing vascularization. You've all heard of apoptosis? Okay? You get a lot of apoptosis under those circumstances, and you get reabsorption by mom, by the tissues in the uterus. So you don't get bleeding, but you get reabsorption of the tissue, a regression back to the baseline. Okay. And that's going to occur in virtually all species that share this kind of uterine proliferation cycle. Okay, so when is pregnancy going to occur, if it's going to occur during this period of time? When does fertilization occur? You got ovulation here. What are we producing when we ovulate? An egg, okay? An egg that's capable of becoming fertilized. So when does the actual fertilization occur? Right after, or at least in this window. Okay? So shortly after ovulation. I'm going to go through the events surrounding fertilization and the early events in pregnancy. What this graph is trying to show you is what happens if, in fact, we have a cycle where the follicle fails, where it doesn't get to the point of ovulation. What is the time between this point and this point if, in fact, no viable follicle? Okay. What's the total length that we normally associate from day 0 to the end? About 28, 29 days. Okay? So what happens to this part if, in fact, you get no viable follicle that would give rise to an ovulation? Okay? It should get longer. Why should it get longer? Okay. You get no ovulation, so this doesn't occur. I should put that over here. So that doesn't occur, and you don't get a CL, you don't get a rise in progesterone. You simply go on to the next cycle, okay? The next wave of follicles growing in the ovary. Remember I said there's a lot of variability in timing of the length of the cycle? Near the time of puberty, after pregnancy, near the timing of menopause. That's the upshot of there being a lot of variability in the follicular phase of the cycle having to do with follicles failing. The time of the lifespan of the corpus luteum is pretty well situated at 10 plus or minus 2 days. The other part of the cycle can be a lot of variability. Okay? So unless you're in the middle years of your reproductive years, when you know that the next cycle is 29 days out, okay, trying to use a calendar to time ovulation is a problem, because you've got variability in the cycle length. All right. Now, what else can we extract from this? So variability in cycle length. So this implies and that's because of variable follicular phase. Oh, okay. A couple of other things. If I have an individual who's young, hasn't had menses yet. Menses is what? What does that represent? Not of the follicle, shedding of the endometrium, the thickened endometrium. And why did the endometrium thicken? Pardon?
To support the AP.
It's thickening to potentially support a fertilized egg, okay? And what's driving it to thicken? Not progesterone. Progesterone differentiates it. Estrogen is what drives it to thicken. Now, in this young individual who hasn't had menses yet, could they get pregnant?
No.
Yes,
Why?
it's possible because ovulation occurs before menarche or first menstruation. So
Okay. Because ovulation has to occur before you get menses. You have to have a viable corporal lutea crashing before you get a menses. So you can get a fertilized egg shed and implanted at early pregnancy before you ever see a menses. Okay? That's one way you get 13-year-old mothers or 12-year-old mothers. The other one is your brother is 13 months younger than you are. Okay? What happened there? How long is pregnancy in the human? 9 to 10 months.
that's 40 weeks,
Pardon?
40 weeks.
40 weeks, okay. But 9 to 10 months, about 9.5 specifically. Okay, so what would have happened under those circumstances? Mom gives birth. She lactates intensely for at least a couple of months. All right, let's take this. So pregnancy was 10 months. Birth, lactation for 3 months. Okay? Then we've got 13 months later, birth. 10 months of that is pregnancy. So what's going on? And let's say she never had a cycle. She never had menses in between. What happened? She ovulated, and then what happened? What? She got pregnant. She got pregnant before she had her first menses post-pregnancy. Okay? That happens a lot. Okay. So remember I said you got a lot of variability here? Okay. So you end up with a lot of pregnancies in these variable periods. And they happen in many cases because the woman resumes intercourse before she ever has a menses. Sometimes thinking she's safe from getting pregnant without contraception. And the World Health Organization agrees with that up to about 6 months, particularly if lactation is intense. If lactation is not intense, the number is 2 to 3 months before resuming contraception. Okay, so knowing a little bit about timing in the female cycle makes life interesting. Okay. Let's go to, I don't want that one. Let's go to So let's talk about the process of fertilization. So, timing of ovulation, so mid-cycle of the female cycle, ovarian cycle, it's going to shed this cumulus oocyte complex. There's a lot of cumulus granulosa cells surrounding the zona pellucida, which surrounds a space, paravitalized space, the oocyte, which has completed meiosis 1 and extruded the first polar body. That's at the time of ovulation. This complex is picked up within a couple of hours of ovulation and brought by the fimbria, the cilia and the fimbria, through the os, or the opening of the fallopian tube, into the fallopian tube proper. This first stretch of the fallopian tube is called the ampulla. You progress in through the ampulla, and by day 1 to 2, often late on day 1 after ovulation, you have the egg intersecting a population of sperm, which were deposited a few days to a few hours beforehand. It takes at least a few hours for sperm to make their way through the cervix, through the lumen of the uterus. And by the way, pictures of the uterus are often misleading. They show this nice big roomy area, okay? In matter of fact, the uterus is more like your fist, where the space between your fingers is relatively constrained. It's more like a fluid channel, okay, a thin fluid channel that they're passing through. And they're migrating, and they'll get up into both fallopian tubes. So there's a lot of loss off in one fallopian tube. There's a lot of loss in the in the vagina itself. There's loss going through the cervix, and there's loss to immune cells that are embedded in the wall of the uterus. So there's lots of sperm loss. So even though you start with 200 million, by the time you get up here, you're down to numbers like 50 to 100 sperm. So very, very selective process for sperm that are actively forwardly mobile and potentially capable of interacting with the egg. They become motile by deposition into the fluid in the vagina, which is somewhat acidic, helps strip away those coating proteins in the process called capacitation. They gain the capacity for forward motility. As they're moving forward up here, they're still capacitated. They haven't fully matured. Sperm don't fully mature functionally until they interact with this cumulus oocyte complex. And it's only at that point where the sperm undergo this process called the acrosome reaction, where they shed the outermost layer of the head of the sperm and essentially bear the proteolytic enzymes that are embedded in the inside membrane of the acrosome. So you've got capacitation of sperm in acidic media, for example, vaginal fluid. And then you've got acrosome reaction This is final functional sperm maturation at interaction with cumulus oocyte complex. You can get longer words. Okay, so sperm aren't fully mature until they're interacting out here in the ampulla. While this has been passing toward the middle of the fallopian tube, the granulosa cells have been extruding lots of glycoproteins, mucin-like proteins. And so you get something called cumulus expansion, where you get a lot of this protein-like material surrounding. It's like a jelly-like coat around this cumulus oocyte complex outside the zona pellucida. You're also, once you've interacted with the sperm and the sperm has penetrated through the zona into the paravitalizing space and interacted with the egg, that's when the egg is stimulated to complete meiosis II, to extrude the second polar body to form the female pronucleus. And it's the fusion of the male and the female pronucleus that completes the act of fertilization. I've got some other slides of this I'll show you in a minute. Once that occurs, you start to see what are called, the early embryonic divisions. And the cells get smaller and smaller with each division because at first, all of this is occurring in what's left or within the zona pellucida. The granulosa cells and the jelly-like coat that they've created get lost over the next short period of time, but cell divisions continue and you get a cluster of cells that's starting to lose the zona pellucida in a process called hatching. So mammalian hatching is occurring around the time that this complex gets to the junction between the fallopian tube and the uterus. This cluster is about 16 to 64 cells. It's called a morula. Does anybody here a Greek background? Okay. Does anybody know what morula means? It's a cluster of grapes. Okay. And then you get, as you move into the uterus, you start to see some differentiation in the cell types that make up that initial cell grouping. And they form a ball called the blastula. And the blastula, about 90% of the cells make up the outer layer of cells of the blastula. Those are what are going to go on to form the embryonic portion of the placenta. The rest of the cells, the smaller group, form what's called the inner cell mass. And that inner cell mass is what's going to go on to form the embryo proper. All of this is occurring, so you're entering the uterus somewhere around day 3 to 5 after ovulation. And by the day 5 to 7, this complex has continued to grow, and you start to see interactions with the endometrium, the outer layer of the endometrium, and the uterus. Now, this is still at a time when progesterone levels are normally high. So these are proliferated, they're differentiated, and they're just primed and ready to accept a fertilized egg, which at this point would be a late blastula or an early trophoblast. Okay, so let's take a look a little bit more carefully at that process of fertilization. So as the acrosome reacted sperm, notice it doesn't have the outer layer of the membrane, outer membrane layer of the sperm, or the outer layer of the acrosome present. You bear the inner layer, which contains these proteases that allow for penetration through the zona, actually through the glycoproteins in the surrounding the complex and also through the zona pellucida. This interacts via specific proteins, binding proteins, with binding proteins on the egg. Does this, a protein interacting with a protein here, does that sound like anything you've heard of before? Protein binding with a protein on the surface of a cell. What does that sound like? Hormone or receptor, okay? So the protein on the surface of the sperm is like a hormone interacting with a receptor on the surface of the cell, of the egg cell. that interaction stimulates the oocyte to increase intracellular calcium levels. And there are some fun movies that actually show what happens. It'll show a spot if you use a dye that's sensitive to calcium levels, and it'll actually show it starts to change color at the point of sperm-egg interactions, and then the calcium kind of goes over the surface of the egg, sometimes back again. And what it's doing, what that calcium surge seems to be doing, besides stimulating the egg to resume meiosis II, is it's stimulating the egg to exocytose these granules that sit just under the membrane. Those are called cortical granules. And those cortical granules contain enzymes that alter the membrane of the egg so no further sperm can bind, and that also harden the zona pellucida, cross-linking it, making it again more difficult for additional sperm to get to the egg. Okay.
Professor?
Yeah.
In vitro fertilization, this all happens in a test tube? Like,
Okay. In vitro fertilization, okay, you can get several flavors of it, okay? In one version, you simply take the oocyte cumulus complex at about this stage, and you place it in a dish with sperm that have undergone capacitation. Now, those sperm, once they interact with that complex, will undergo an acrosome reaction, and you'll get this kind of event, the kinds of events that I've shown here. That was the original in vitro fertilization approach. Since that time, there are a variety of other versions of it that have been undertaken. One of which is to take the sperm or a late stage in sperm development, and even now at this point, down to the earliest stages of sperm developments, so long as you have a 1N cell, so you could get, spermatids would work. Any of those cells, you take the nucleus, and you can inject the nucleus or even the entire cell into the cytoplasm of the egg and get a situation that, along with stimulation of this calcium flux, which you can do chemically, will cause sperm-egg fusion and fertilization in vitro. That's another version. Another version is to take the sperm, allow them to interact with zona pellucida that have no eggs in them, and then take those sperm and inject them in the perivitelline space of fresh eggs, okay, and allow them to fuse. So, like I say, there are a variety of them. Injection of the nuclei and introduction of activated sperm in the perivitelline space are the most efficient ways to get fertilization of the egg. It is difficult to say exactly what the efficiency is, because normally it's dependent on how efficient you are in causing an implantation. And this process in primates, and in humans particularly, is very inefficient. So something on the order of 50 to 70% of eggs that get to this point, fertilization, are lost prior to establishment of an active pregnancy. So it's difficult to say how efficient this is when you're losing half to 70% of what you started with by the time you get to implantation. Okay, so calcium flux, stimulating cortical reaction, which changes the nature of zona pellucida and the nature of the surface of the egg. Why would the egg want to prevent multiple sperm from interacting? Wouldn't multiple sperm interacting with the egg be good because it would optimize the probability of fertilization? Is there a problem there? What's the problem? What's the problem? You said yes.
They both have a lot amount of DNA required to make a
So each sperm
carries half.
carries half the chromosomes. And so what if you get 3 of them in? You get trisomy, you get aneuploidy, you get multiple nuclei present, or pronuclei present. You get fusion of those multiple pronuclei, and you're going to get aneuploidy. Even if it survives through the first several divisions, the daughter cells are going to be asymmetrical in the number of chromosomes they have, and it's very unlikely under those circumstances that they're going to survive. If you have trisomy or multiplication of several small chromosomes, those sometimes get by and survive into pregnancy and ultimately after birth. Okay, that's where trisomy 21, for instance, comes from. That's one of the ways it comes up. Okay, so this is fertilization and the process of fertilization. So it's a dance. A little on female contraception. We talked about scarification of the tubes and the fact that it would disrupt, you can see from that last slide, if you scar the lining of the fallopian tubes, you're going to prevent progression of these events to the point of implantation and the induction of pregnancy. If you tie this off, you're going to prevent at least half of the pregnancies from occurring. Why did I say half? Okay, because there's a second fallopian tube and a second ovary. All right. So you tie those off, you chemically scarify this, and that's one way pregnancy can be prevented. And that, in fact, is pretty common in developing nations. These numbers will have changed a bit because this slide is several years old, but they're going to be in the same general region. The use of steroids, particularly chemical contraception, accounts for something like 1/3 in the U.S. and about 1/6 in developing world. Barrier contraception, much smaller numbers. The use of IUDs, because they tend to be expensive and because there aren't medically trained personnel to put them in place, IUDs, intrauterine devices, accounts for the low numbers, particularly in the U.S. Developing countries, they're still fairly common, almost comparable to what you see with tubal ligation. Notice that the hormonal contraceptions, in large part because you have to go back every so often to get them, accounts for relatively low numbers. There are some long-term injections and implants of progesterone-like compounds that are fairly popular and are becoming more popular both in the U.S. and developing world. Okay. Other barrier types, we talked about IUDs. Traditional methods still commonly used, particularly outside the U.S., and this varies in the U.S. By survey. But the numbers are normally fairly low. Periodic abstinence, that is the timing of intercourse to prevent pregnancy, is pretty low. And the use of condoms is, again, popular in the U.S., less so in the developing world. Okay. And, this is just talking about the other end of the reproductive cycle in human, or in primates, particularly human females. and that is as women age, their bone masses change, and you get a change in the levels of estrogens. As estrogen levels fall, you can get a loss of bone mass and an increase in the risk of fractures occurring. Some studies of the use of hormonal steroids for women who are about the age of menopause, replacement therapy, show an improvement in that risk of fractures. This goes along with improvements in the risks of heart disease and some cardiovascular problems, which are elevated in elderly women just as they are in elevated men. You also get the elevation of FSH, and in fact, you can now walk into a drugstore and get a kit for measuring your FSH levels in urine. Okay? Much like you could use a pregnancy test kit. And those test kits are looking at FSH and looking at the change or the rate of change in elevation of FSH near the end of the reproductive cycle. All right. Oh, this is hormone replacement therapy, the various things that it improves: strengthens bones, lowers LDL cholesterol, raises HDL, reduces menopausal symptoms. The list goes on. More important is that it tends to improve cardiovascular tone. The bad effects: it increases breast cancer risk, increases uterine cancer risk, so reproductive tissue risk, and increases the clot risk of blood clotting, because estrogen plays a role in blood clotting.
Professor?
Yeah.
Is that why a lot of female contraceptives also have the increased risks of those things?
Yes, exactly. Anytime you elevate estrogens for prolonged periods of time, you can potentially have these kinds of effects, but you also have these kinds of effects. So it's a cost benefit. You know, what do you want to prevent? What do you want to take a risk on? Turns out that in most of the world, pregnancy is a very high risk physiological state because birth is problematic, particularly when you're away from potential medical attention. It's a natural process, but there are enough things that can go wrong where if you're away from potential medical attention, you can get infected, you can hemorrhage, you can have all sorts of problems like that. Okay. This is just a couple of different. Okay, I'm going to skip those. Escape. All right. So we're pregnant now. What time is it?
You have 4 minutes.
4 minutes? 4 minutes to go from pregnancy, huh? Let's see.
Can I ask like a random question?
Yeah, you can ask a random question.
So when someone has like an ectopic pregnancy, does that mean that it's implanting within the fallopian tube?
An ectopic pregnancy is where an egg fertilizes. Usually that fertilization is in the ampulla, okay? So if there's any retrograde motion, so if the fibria aren't working very well, it can move to the exterior of the fallopian tube. And from there it can float to various places. It can attach to the outside of the ovary, to the outside of the fimbria, to the outside of the uterus, to somewhere in the abdominal cavity, somewhere else in the abdominal cavity. The first few days of growth and differentiation of the embryo are pretty autonomous. Remember, it's in a space that has no vascular connection immediately to the mother. So it's like putting it in a petri dish and allowing it to grow. And it will do that as long as it has access to nutrients, access to enough oxygen, and recognize the oxygen tension in that area is low. It's not anywhere near what it would be near an arterial blood supply. So it can survive in kind of in floating in an animated condition for probably a week anyway. And once it gets to that point, it has developed the capacity to invade surrounding tissue. Okay? So it can attach in a number of places and give rise to potential problems.
So, in every case, it's just removed once it starts creating those problems?
In the vast majority of cases, it's removed in large part because it can potentially cause a hemorrhagic condition. If, for instance, it continues to expand in the fallopian tube, which is richly vascularized, it could cause rupture. Attaching to the uterus could cause rupture. Other organs, again, can cause vascular problems. Not to say anything about hormonal problems. Next time, folks, we're going through pregnancy, and by the end of the week, we are going to do sex determination.